All right. Hi, everyone. Welcome to this month's webinar of the Washington Healthcare Facilities Community of Practice. My name is Ryan Kronk. I'm with UNC. As you're joining the webinar, please feel free to add your name and organization to the chat box. Today, we have a really exciting webinar lined up with several speakers from the PROMISE Consortium, which includes studies examining environmental cleaning and hand hygiene practices across healthcare facilities in Uganda. So first, we're going to start off with a couple announcements, as we normally do, and then I'll turn it over to our speakers. We will have a question and answer session, so please be sure to use the chat box during the webinar and let us know any questions you might have. If you'd like to ask a question live to our speakers, you can feel free to raise your hand and we'll unmute you so you can ask them. Next slide. As we previously mentioned, we are launching a working group focused on the work of faith-based organizations to advance Washington healthcare facilities. We had an initial meeting yesterday, which was really great, and we're excited to invite more partners to that. So if you have any interest in joining, please feel free to email Nikki. As a reminder, feel free to invite your colleagues to the community of practice. We do have a LinkedIn group where you can connect with ideas for speakers and topics, or if you have ideas for a future webinar, feel free to email us. And as always, check out the washingtonhcf.org website. Stay tuned for a lot of really exciting updates in the upcoming year after the summer break and summer holidays. We have a lot of new ways that you can connect through the community of practice. With that, I'd like to introduce our speakers. We have Dr. Richard Mugambe, who's a senior lecturer at Makerere University School of Public Health, and Dr. Judith Nanyondo, who is the principal investigator for the Reckitt Global Hygiene Institute project at the Institute or Infectious Disease Institute (IDI) in Uganda. And they have several colleagues joining them as well. I'll let them all introduce themselves as they present. So, Dr. Mugambe, please feel free to take it away.
Thank you so much, Ryan, and thank you to all the colleagues that have participated in organizing this webinar. Once again, I'm Richard Mugambe, and I work with Makerere University School of Public Health, where we've been conducting research as part of the PROMISE Consortium with funding from the Gates Foundation and the Reckitt Global Hygiene Institute. Today, I'm going to present about environmental contamination in selected healthcare facilities in the Greater Kampala metropolitan area, and I'll be presenting with Michael Omodo. Next, please. Poor environmental hygiene contributes greatly to a high burden of healthcare-associated infections, especially in low and middle income countries, where indeed the challenges of environmental contamination continue to persist as a result of improper environmental cleaning, poor healthcare waste management, as well as improper wastewater management. It has been noted in different research projects that indeed environmental cleaning is a key infection prevention and control strategy. But unfortunately, in many low and middle income countries, including Uganda, there are many gaps associated to environmental cleaning. And our formative research findings pointed to two major challenges related to environmental cleaning, and this included a lack of appropriate knowledge among the janitorial staff, as well as a lack of supplies in some of the facilities. And as a result of that, we designed an interventional study based on a quasi-experimental design. And today, I'm happy to present to you some of the findings from the baseline study of that intervention study that is currently going on in Uganda. Next, please. So the objectives of the baseline study were two. One, to quantify the prevalence of 8 priority bacterial pathogens in environmental samples drawn from healthcare facilities in the Greater Kampala metropolitan area. And these 8 priority bacterial pathogens were informed by existing literature in Uganda. Secondly, we sought to characterize the phenotypic and microbial resistance profile of the recovered isolates with particular attention to MRSA, VRE, ESBL, and carbapenem resistance phenotypes of public health importance. Next, please. So in terms of the methods, the study was done in the Greater Kampala metropolitan area within selected healthcare facilities, and these facilities were purposively selected to include high patient load facilities as well as facilities that had functional IPC committees. Next, please. Next, please. So in terms of the sampling, next, please. In terms of the environmental sampling, we took swabs, surface swabs, from 9 healthcare facilities, and the sampling points were door handles, working tops, bed rails. We also took swabs from medical equipment, among others. And the departments where we took these samples from included the inpatient wards, the laboratories, theaters, toilets, and other healthcare associated locations, especially in the areas where care is offered to the patients. Altogether, we collected a total of 108 surface swabs. We also took water samples in these 9 facilities, and the water samples were taken from taps and sinks, again from the same departments of interest, and altogether we had 41 water samples. Next, please. So what did we do for us to quantify the organisms? We had different culture media that were used for the different organisms of interest. For Staphylococcus aureus, we used Manito salt agar. For Pseudomonas aeruginosa, we used the cetrimide agar. For Acinetobacter, we used the Maconke agar. For Enterococcus faecalis, we used Enterococcus agar, and we also used Maconke agar for E. coli, Klebsiella, and Enterobacter, and isolation was done by incubating these organisms at 37 degrees centigrade for a period of between 18 to 24 hours. Next, please. So for the antibiotic susceptibility tests, these tests were performed using the Kirby-Bohr disk diffusion method, where antibiotic discs containing different concentrations of the antimicrobial agents were placed on agar surfaces and incubated at appropriate temperatures within a period of 16 to 18 hours. The diameters of the zones of inhibition around each disc were measured, and results were reported as susceptibility, intermediate, or resistant based on established breakpoints in the standard guidelines. Next, please. So in terms of the results, next. In terms of the results, all of the samples, the 149 samples that we collected, the highest positivity was recorded for Staphylococcus aureus. And when it comes to the distribution of the microorganisms across the different departments, we realize that for the inpatient department, the highest positivity was recorded for E. coli in the inpatient department, and also in the inpatient department had the highest positivity for Klebsiella pneumoniae. In the laboratory, the highest positivity was recorded for Staphylococcus aureus, but we also realized that the theater had very high positivity for Staphylococcus aureus. When it comes to the distribution of the microorganisms based on the sample type, we realized that that surface swabs had the highest positivity for Staphylococcus aureus, and water samples had the highest positivity for E. coli. Next, please. When it comes to the antimicrobial resistance profiles, I will share the antimicrobial resistance profiles for only 2 organisms in the interest of time. But I would like to note that 4 main organisms with the largest isolate yields were considered when we were taking the susceptibility tests. And here I would like to note that for Staphylococcus aureus, the largest isolate yields were observed for Crimoxo as well as penicillin, followed by erythromycin. Next, please. For E. coli, the largest isolate yields were recorded for ampicillin, followed by tetracycline. Next, please. When it comes to the conclusions, we conclude based on these findings, that healthcare environments in the Greater Kampala metropolitan area harbor a high burden of clinically relevant bacterial pathogens, and we also observe that the substantial prevalence of MRSA phenotype S aureus, as well as the ESBL producing E. coli and emergent lineazoid resistance signals in Ephysium indicate that environmental reservoirs in the Greater Kampala metropolitan area healthcare facilities are an active source of resistant pathogens. Next, please. What are the implications of these findings to policy and to programs? One, we note that it's important for doctors to pay attention and use resistance partners to choose the most effective antibiotics for treatment. Secondly, we also note that district-level resistance partners can highlight hotspots where stewardship, infection prevention, and supply chains can be critical in making adjustments for the most urgent interventions. And then thirdly, evidence from this study feeds into the Ministry of Health decisions on which antibiotics to prioritize, restrict, or monitor these activities can be done closely. Next. That brings me to the end. Thank you so much.
Thank you so much, Dr. Richard, for that. And I'll move on to the next presentation. My name is Judith Nanyondo. I am the principal investigator to the RGHI hand hygiene and surface hygiene study at the Infectious Diseases Institute. And I'll majorly talk about hand and surface hygiene in postnatal and surgical wards in Masaka regional in the Masaka region in Uganda, which is the key area for this study. Next slide. For this presentation, I will co-present it with a colleague, Fred, who will be joining me very soon. So why are hand and surface hygiene in healthcare? Why hand hygiene and surface hygiene in healthcare facilities? I would like to highlight that hands and surfaces, especially contaminated hands, are very critical drivers of infection transmission, and therefore become very critical in ensuring that for us to be able to curtail some of these infections, we need to put in place interventions to break the pathways. So environmental cleaning and hand hygiene breaks these pathways. Next slide. So what are we doing in this study? In this study, our focus is mainly three things. One, we are trying to explore the barriers and facilitators to hand and surface hygiene compliance among clinical staff and cleaners in healthcare facilities in the Masaka region in Uganda. We are also designing data-driven hand and surface hygiene care bundles using a human-centered design approach, and after which these have currently informed the next objective, which is to assess the effectiveness of hand and surface hygiene care bundles in improving compliance with hand and surface hygiene practices among clinical staff and cleaners in postnatal and surgical wards. Next slide. So how are we proposing to achieve this? Next. Next. So there are mainly three things that we are proposing to achieve this using a phased approach. Phase one is the formative assessment, for which the results that we are presenting today are majorly from the formative part of the study, where we've done a lot of systematic literature review. We've done a mixed methods data collection and analysis. And the next phase was a human-centered design, where we sat together with the key stakeholders, the healthcare workers, the leaders in the healthcare facilities, the cleaners, to sit together to design interventions that we think will be able to improve hand hygiene and environmental hygiene. And thereafter, the next phase was the implementation and evaluation, which included the implementation of key agreed upon bundles, and then we will be having mixed methods evaluations. So allow me to invite my colleague Fred to just take us through the bit of the formative assessment, the tools we used, and some of the key results. And I'll come back again to just share with you some of the key policy and practice implications. Over to you, Fred.
Okay. Thank you, the PI. Greeting to you all. My name is Fred Tunomisha. I'm an IPC specialist supporting this project or study. So the tools that we used for the formative assessment, we had 4 tools: facility assessment, knowledge, attitude, and practice survey, structured practice observations, and key informant interviews. So for the facility assessment, we looked out for the in charges or hospital managers, IPC focal persons. And then for the CAP survey, we were able to interview around 24 clinical staff and cleaners. And then for the structured practice observations, we mainly used the WHO hand hygiene observation tool based on the 5 moments, and we are able to observe 50 clinical staff and cleaners, 11 observations. For the KIIs, basically we interviewed 21 clinical staff and 38 cleaners. Next. So looking at the results from the hand hygiene observations, the total hand hygiene compliance to 22%, and this varied according to the 5 moments, with after body fluid exposure having the highest compliance rate of 55%. Next. So this has already been highlighted. The lowest compliance was basically before aseptic procedure, as you can see from our results that demonstrates only it was just basically 0%. The healthcare workers were not practicing hand hygiene at that moment. Next. So looking at our objectives that we set out to do, one was about the barriers and facilitators of hand hygiene compliance, and we look at 40% of the patient care rooms lacked appropriate hand hygiene materials like ABHR and soap and water, and only 27% of the rooms had hand washing stations. However, 85%, looking at the self-report results, 85% of the healthcare workers mentioned that they were complying with hand hygiene, but practically after observation, we only identified 22%. Also, 96% of the healthcare workers were confident that they know how to perform hand hygiene, but looking at the median hand hygiene knowledge score was only 57%. Next. So we also we found that only 10% of the facilities had dedicated team to promote and implement optimal hand hygiene, while over 40% of the clinical staff interviewed had not received hand hygiene training in the past 1 year. As you can see, one of the quotes that the staff that I supervise, I feel they haven't received enough training. There is a need for continuous training. People need to be reminded. Next. So many critical steps in the cleaning and disinfection processes were being missed, increasing the risk of transmission of healthcare-associated infections, whereby only 2 cleaners were observed preparing disinfectant solution, and none measured while preparing the disinfectant solution. So they were just pouring the disinfectant without following the proper measurement or following the correct procedure for measuring the GIC or chlorine. Also, staff did not practice hand hygiene before beginning or after completing cleaning and disinfecting activities, and yet in the processes of cleaning or environmental cleaning, the first step is hand hygiene. Next. Staffs were also aware of the value of their work in environment, and they were eager to learn more, whereby there was a general 67% cleaners mean and knowledge score, while 80% of the cleaners reported being confident or very confident in their ability to carry out their cleaning duties. However, only 30% of cleaners reported feeling they had sufficient training on cleaning and disinfection of medical facilities. This can also be highlighted, as you saw from my previous slide, whereby most of them did not know how to do the proper disinfection process. Next. Next. Staff take pride in their work, and interpersonal relationships play a key role in cleaners' ability to carry out their duties. So, for example, cleaners felt segregated and not valued for their work. This is because there was sort of conflicts and misunderstandings between cleaners and patients, caregivers, and clinical staff, which serve as a barrier to ensuring a clean and safe healthcare environment. 80% of the cleaning staff reported that leaders supporting and openly promoting cleaning would be effective or very effective in permanently improving environmental cleaning at their facility. Just to highlight that this demonstrates that leadership support is able to improve environmental cleaning within healthcare facilities. Next. Next. The way forward. So having conducted the formative phase, then we are able to come up with hand hygiene and surface hygiene bundles, intervention bundles, to be able to fix the gaps that have been highlighted above. And one of it is ensuring consistent availability of hygiene and IPC resources needed for optimal hand and surface hygiene practices, strengthening knowledge, skills, and accountability of healthcare workers, cleaners, patients, and caretakers, improving compliance with hand and surface hygiene standards. This has been done through availing hand hygiene supplies and environmental cleaning supplies within the Makerere region for all the 18 sites that we are conducting this study. Promoting a culture of safety and collective responsibility for infection prevention with surgical site and postnatal wards. Here we are involving leaders within those facilities to act as role models as a way of promoting this culture of safety. Institutionalizing systems and structures that support ongoing hygiene improvements. These are part of the intervention bundles that we have developed and being implemented within those 18 sites. I hand it over again to the PI. Thank you.
Thank you so much, Fred. Next slide. So the intervention bundle that was mentioned was developed with the key stakeholders that I earlier mentioned, that include the healthcare workers, the districts and the facility leadership, and then the cleaners. And that bundle is highlights the key areas that Fred has just talked about. So what are some of the key implications for policy in Uganda from the formative part of the study that we conducted? And as you have listened and trying to synthesize those results, there are mainly 4 things that we would like to highlight. One, it's important to prioritize hand and surface hygiene as key quality of care and patient safety indicators across healthcare facilities. I know the government of Uganda is trying to make sure that the Ministry of Health is trying to make sure that some of these indicators are already included, and this remains a key priority to ensure that at least as much as possible, many of these indicators are well integrated and enforced. The other is strengthening infection prevention and control financing to ensure that there's consistent availability of hygiene infrastructure, supplies, and training resources. This remains a key priority and a critical gap that we have within our health facilities. Another implication is institutionalization of regular competence-based training on both hand hygiene and environmental hygiene for both our clinical staff and our cleaners. This also remains extremely critical. Lastly is enhancing monitoring and accountability systems through routine audits, direct observation, and feedback mechanisms. Those are some of the policy implications. Next slide. In terms of practice, we would like to highlight some implications that include ensuring continuous access to soap, water, alcohol-based hand rub, and environmental cleaning supplies at points of care, focusing behavior change interventions on improving hand hygiene before patient contact and aseptic procedures where compliance was lowest, then implementing routine mentorship, supportive supervision, and performance feedback to bridge the gap between perceived and actual practice. The other is standardized environmental cleaning procedures through standard operating procedures, checklists, practical training on cleaning and disinfection. And lastly, mechanisms to promote a culture of shared responsibility by engaging facility leaders, clinicians, cleaners, patients, and caregivers in infection prevention and control efforts. As we come to the end, next slide, what is the key take-home message? So the key take-home message from the formative part of our study, and as we continue implementing this study, is Improving hand and surface hygiene requires a systems approach that combines adequate resources, continuous training, effective monitoring, leadership support, and recognition of cleaners as critical partners in infection prevention and patient safety. Yeah, thank you so much for listening to us, and back to you.
Great. Thanks to all our presenters for excellent presentations. Very exciting work to hear about everything that's going on in Uganda. So I think we have a few questions already in the chat. If you have other questions, please feel free to drop those into the chat. Or if you'd like to raise your hand, we're happy to let you unmute and ask the presenters yourself. So there's a couple questions that have come in already. One around the healthcare workers that were interviewed. What type of healthcare workers were interviewed for this survey? And then I'll ask a second question as well. What was the package of training on hand hygiene? If you could elaborate a bit more on those two things.
All right. If you could just put back the presentation, I think the health workers that were targeted for the interview, that's slide number 5 that has the detail. Slide number 5 has the detail of who was interviewed. Oh, sorry, that's the IDI presentation. Yes, that one. Yes. So the respondents are right there. On your extreme right, those were the respondents. We had the in-charges, IPC focal persons, clinical staff, cleaners. Yeah, those were the respondents. But then in terms of the package, let me see the question, the package of the hand hygiene training materials. So we used the WHO training package that has both didactic and practical sessions on how to conduct hand hygiene, but also how to monitor compliance for hand hygiene using the WHO tools. So it was that all-encompassing package. Thank you.
Great, thank you. We have Richard, would you like to ask your question? I see your hand raised. If you'd like to unmute.
Hello.
Hi, we can hear you. Please feel free to ask.
Can you hear me, right?
Yes, please ask your question.
Yeah. So, Richard Kimwanga from University of Dar es Salaam. I can also like to congratulate both presenters for very nice and insightful presentations. Just a question to Judith, and of course, I'm just picking up from the slides where she presented the implication for policy. I just understood that one of the policy recommendations is to strengthening the IPC financing. And the questions that I have for that particular point is, number one, I didn't find anywhere in her presentation where the financing for IPC has been talked about. In other words, what kind of research findings that informed that kind of conclusion? That's number one. And number two, maybe what are the current arrangements for the financing of these interventions? And the last one is, given the current situation of global financial crisis, maybe I think it would be very important for her to make the recommendation what should be the innovative financing mechanism rather than relying on the traditional kind of financing mechanism. So those are the questions that are directed to Judith. Just one for my friend Mugambe. I missed in your presentation about the tools that used for analysis and the level of confidence for the application of those tools to give the result that I've just presented. Thank you very much. Can everybody hear me?
Yes, we did hear you, but I think Ryan is on mute, but I could start. Ryan, is it okay if I could just
Yes,
proceed with making a comment?
yes,
Okay.
please feel free to make a comment, of course.
All right. Yes. So thank you so much for such a good question around financing. So financing is maybe we rushed through the slides, but we had something around a budget for IPC. It's one of the areas that was assessed. A majority of the facilities, of course, do not have a budget, a specific budget line for IPC, and where that falls is in one of the core areas. I will some of the core areas, some of our focus areas that we are going to support. The bundle of interventions that we have developed includes an area of institutionalizing systems and structures that support ongoing hygiene improvements. And so that's where it falls. And what we plan to do indeed is looking for innovative ways on how we can use available finances to ensure that IPC interventions are well integrated. The government of Uganda has what they call their funds that they give to districts monthly. The district finances that funding basket, that resource envelope is quite small with so many priorities. However, our plan now is to advocate for the facilities under the districts to see that however small that envelope is, they should be able to include critical areas to support IPC, like paying cleaners, like ensuring that supplies are there. So we are going to be banking on that resource envelope that the government has as we continue to advocate for increase of that resource envelope with less reliance on the international aid. Yeah, so that's our plan of
Great, thank you. Any other comments from the team?
I think there are comments for Richard in the chat, and there was a question that was asked, so maybe he can take them on.
Yeah, so we could go on to Honore's question. How are clusters of outbreaks of resistant microorganisms managed or resolved at the healthcare facility level?
Thank you so much for that question on outbreaks of outbreaks related to these to antimicrobial resistance in healthcare facilities. So first of all, sometimes in these facilities, it may be difficult for such outbreaks to be detected immediately. But part of what these facilities do in case such outbreaks appear is to intensify infection prevention and control activities for purposes of ensuring that proliferation of these organisms is stopped. And then secondly, the people that are already affected by the outbreak are usually treated to ensure that they do not pass on the infection to others. So those are two critical interventions or responses that healthcare facilities usually undertake. Thank you.
Thank you, Richard. Also, I know you have some additional slides in your deck that we've received. Would you like to present on those? Nikki can pull up those slides if you wanted to say a few remarks on any additional results.
No, I think unless something shows up in the questions, I think I talked about many of the issues.
Okay.
There are additional slides that my colleague Habib shared, but I think I'm fine with what I presented.
Okay, great. Just wanted to offer that if that was helpful to you, we can certainly get those shared. We have another question now from Faith. How should bacteria in piped water in labs and health units be handled?
That's for me or for Judith?
Either one, whoever feels most comfortable responding to that question. Or anyone else feel free to call on others from the team if someone
I
else.
think, first of all, if I can respond to that and Judith can supplement. I think, first of all, it's important to have a surveillance system in place to monitor the quality of water that is being provided in the healthcare facilities. In the Greater Kampala metropolitan area where we are currently doing the research, there are a few facilities that have such water surveillance systems in place where they periodically take samples for testing, for physical, chemical, and microbial testing. And they do that internally within their laboratories, but they also send samples to the laboratory at the National Water and Sewerage Corporation for quality control. And in case the results, the internal, the external results point to a situation where the water is contaminated, they respond by either cleaning the tanks or looking for leakages in the supplies in the neighborhood and making sure that those are addressed. So it's important that an assessment is that surveillance is done, but besides the surveillance, it's important to ensure that they periodically assess the different water sources that they have in place for any risks of contamination and ensure that those risks of contamination are addressed. Thank you.
Yeah, I think just to add to that is that in addition to the surveillance, the Water and Environment, the Ministry of Water and Environment and the National Water and Sewerage Corporation ensure that the piped water is chlorinated. So chlorination of the water is one of the key mechanisms to ensure that the bacteria, we have as low a dose of bacteria in the water as possible, but we do know that again, further to that chlorination, the ministry equally has points where they keep checking if the chlorination is adequate as the water moves far from the production unit. They have points where they're assessing if the chlorination is adequate. Yeah, so chlorination is one of the best mechanisms, but the key thing is to ensure that we have sufficient or adequate chlorine within the water to ensure that the bacteria the dangerous bacteria, if I must say, are not left within the water. Over.
Thanks for that. Really helpful insights. We have our next question. I'm going to actually link our next question to a previous webinar we had. So last year we had colleagues from Bangladesh present on water quality sampling throughout a water supply system within the hospital, and they detected different types of contamination at different points where throughout the water system in the facility, new sources of contamination were entering the system, all the way from the source, say rainwater tanks, down to the actual taps in rooms. I'm wondering, so just linking that to the question in the chat, did you consider sampling the other like the sources of water, whether they were from rainwater harvesting tanks or from pumps directly from the borehole? Were there any other samples taken along the water supply chain in the facilities?
Thank you, Ryan, for that question. So we took water samples from different points within the study healthcare facilities. We took water samples from on the external environment. We took water samples from the tanks outside the healthcare facilities, the water storage tanks. We also took water samples from taps within the compounds of the healthcare facilities, and then we took water samples from different points of care, like different departments within the study healthcare facilities. Thank you.
Great, thanks for that. Our next question, it looks like Fred answered or started to answer it in the chat. But Judith and Fred, if you have anything else to add to Dr. Mo's question, were you able to identify the reasons why so few hand hygiene stations had soap? Was it due to poor management of ordering of supplies in a timely manner, or was it due to financial constraints or due to something else? And I see Fred responded that it was basically due to financial challenges. Did either of you have anything else to elaborate on that question? If not, that's okay. We can move on to the next one.
Nothing for me to add. I don't know if Fred does.
Okay, if not, that's fine. We'll move on to our next question. We have a question from Oliver. How were the health facilities in Masaka selected for the study, and is the sample of the health facilities representative of all the facilities in Masaka?
Yeah, I see Fred has responded, but Fred, could you speak over it? You could speak through it, sorry.
Okay, thank you so much. So we looked at so many factors to consider to ensure that we have a representation of all facilities. One, we looked at the facility types, basically public or government facilities, private facilities, and private not-for-profit. And to highlight that for public facilities, we took all the hospitals, all the government hospitals were selected, and then also looked at facility levels such as the hospital and health center 4. For this particular study, we took health center 4s, all the health center 4s within the region, but also the private facilities, especially the hospitals and the private not-for-profit hospitals. A total of 18 facilities were selected, and out of these 18 facilities, we had 14 public facilities and 4 private not-for-profit and private for-profit. So with that representation, it is evident that the results are representative of all the facilities within the region. Over.
Great, thanks for that explanation. Our next question, have you estimated the facility to cleaner ratio required to maintain IPC and wash services? Often due to a lack of trained staff, these services can be compromised.
Fred, could you want to speak through that as well?
Okay, thank you so much. From our results, of course, what we presented was a highlight of results, but looking at the detailed results, one of the biggest challenges we found within the facilities is that the number of cleaners are not proportional to the cleaning rooms that they are supposed to clean. Some facilities we could find 1 or only 2 cleaners for the entire facility, where you cannot for now estimate the ratio. So moving forward, this is noted. We'll have to go back and be able to identify how many cleaners are needed for a certain facility. But from our results, the cleaners were very few compared to the total number of rooms they are supposed to clean within a healthcare facility. Thank you.
Great, thanks. The next question, have you been able to between wastewater and AMR?
Yeah, thank you, Ryan. So we did not look at wastewater and AMR in healthcare facilities. Our focus was on the surface swabs from the different departments that I mentioned and water. So we only looked at AMR and surface swabs and water. Wastewater was outside the scope. Thank you.
Great, thank you. I think some of these other questions are getting answered in the chat. We've got another question here. Given the Ebola outbreak in DRC, what additional measures are healthcare facilities in Uganda taking to prepare for possible Ebola cases in Uganda?
Yeah. So first, I must say that Uganda has also equally declared an outbreak of Ebola. So we do have 20 cases that have been registered, and a lot of measures have been undertaken to ensure that we contain the outbreak. And for now, we have sort of contained the outbreak, but because we still have a critical number of cases in DRC, there is no way we can say that we have contained, since DRC, there's still a number of cases. But that said, within the epicenter, which was the Kampala metropolitan region, and the border districts, a lot of response measures have been done, especially enhancing infection prevention and control, rapid assessments, a lot of mentorship, supplies, all that has been provided. But of course, gaps still remains. As you know, supplies is a very, very big issue. These being consumables, many of these, get finished, and and there is need to look for sustainable ways on how to ensure that these supplies can be available, especially when we need them the most. In other places, in other districts where no cases have been established, there is enhanced preparedness and readiness that is going on to be able to improve infection control measures. Yeah. Over. Fred, I don't know if you'd want to speak through the next question around
So maybe if I
the
can
effect of
supplement.
facility users. Yes, please, Rich.
Yeah, if I can supplement on the Ebola measures on top of the infection prevention and control measures that my colleague Judith has talked about. There is a lot of surveillance that the Ministry of Health is promoting and undertaking, activities around contact tracing and cross-border screening, and also ensuring that there is a dedicated facility to treat the cases that are identified across dedicated facilities to treat the cases that are identified in the country, and ensuring that safe burial is done for the victims of Ebola. Thank you.
Great, thank you. Richard has another interesting question. Did you look at the effect of facility users' pressure on the level of environmental contamination?
No, we didn't look at that.
Okay, great, thanks. Next question. Is there any correlation between medical waste management and the risk of antimicrobial resistance? Or was that outside of scope of your project?
Yeah, again, we didn't look at waste management, and we didn't look at those associations. Our focus was really to quantify priority organisms across the different departments, inpatient, maternal, children's ward, laboratory, among others. So we sought to quantify and also establish microbial resistance profiles. And then after the baseline, which we concluded 2 months ago, we sought to implement an educational intervention. And this educational intervention is currently ongoing in the study facilities. The educational intervention is targeting in IPC committees, as well as janitorial staff and other healthcare workers. But we've also provided environmental cleaning supplies in these study facilities. And we are going to continue with the intervention for 3 months. And then after that, we shall do an end-line evaluation to see if the intervention has caused changes in the levels of environmental contamination in the study health facilities. So that is the focus of our research. Thank you.
Great, thank you. Let's see, I'm going to bundle these last two questions. So we have one from James, whether or not should we, I like this, he poses it to everyone who works in healthcare facilities. Should we aim to attain zero microbes in healthcare facilities, or should we separate critical and non-critical zones? And then also a question from Dr. Amin. Another important challenge is lack of skilled plumbers for small fixes. Would you please share your experiences related to the maintenance staff? Sorry, two unrelated questions, but if anyone wants to jump in quickly with responses in our last couple minutes.
Yeah, thank you. I'll start with Nuhu. The challenge of lack of skilled plumbers for small fixed watch facilities, such as to fix broken. Yeah, I think that's a challenge that we've observed in Uganda. But I want to say that it's not a very big challenge because there are many vocational institutes that are producing plumbers with skills to really work on these wash provisions in healthcare facilities. To me, I think the biggest challenge with these wash infrastructure in healthcare facilities is mainly a lack of finances. Many facilities struggle with financing wash and IPC activities, and this is both in public and private facilities. But where finances are available, it's always possible for them to get a plumber to fix these issues. The other question is, yeah, I think that addresses Nuhu's question. James asks a question on whether we should target zero microbes in healthcare facilities, or we should separate critical and non-critical zones. I think this is an interesting question. We may not be able to achieve zero microbes in healthcare facilities, but it's important to, as James indicates, to really have those dimensions where we can be able to categorize and know that in this department, for example, in theater, we cannot afford to have organisms in theater because of the kind of activities, the operations that go on there. So there are areas in the health facilities where we need to have the highest level of environmental hygiene to ensure that there is no contamination at all, or very limited contamination for purposes of protecting the patients that go in those departments. But in some departments, probably there is a possibility that that the level of environmental hygiene can be slightly lower, but that does not mean that we should not put in interventions in place. Thank you.
Great, thank you so much. Well, that's our time. Thanks everyone for joining. Please, as a reminder, if you'd like to join our working group, email Nikki. We have more working groups coming. Stay tuned for our next webinar. We will see you all in September, and hopefully some of you at the UNC Water and Health Conference. Have a great rest of your day and a great rest of your summer. Thanks, everyone. Take care.